Call the meeting to order. First on the agenda is the approval of the minutes from November 21st.
So moved.
Thank you, Jan. Second.
I'll second it.
Motion and a second. All in favor, please say aye.
Aye.
You're in. It looks like you're in charge of the medical staff meeting summary.
So they just had med staff meeting this morning, so
Oh.
this is like hot off the presses.
Fresh.
Medical staff did review their medical staff bylaws and rules and regulations, as well as looking at their committee assignments and the department advisors for 2024, all of which there were no changes made, and they approved all of those. So kind of that end of year, get all that stuff swept up type of thing. So all of that went through. I think Laura, are you gonna go over the ACO stuff, or do I need to?
Not in depth, so you can.
Okay, a couple of things that were brought up with med staff this morning from the ACO. Breast cancer screenings, and that's basically your mammographies. They're changing that from age 50 to 74 down to 41 to 74. So not that people don't get mammos, but that's what they're looking at now. The health coaches at the Real Health Clinic are doing their annual wellness visits. They're completing about 150 a month, so they really have increased on that. And tobacco screening, they did start that at age 13, and they're moving that down to age 12 now. So basically asking if they smoke and going further with that. So just some changes for the medical staff, so they were aware of those this morning. John Pecci and Mary Peterson came to the group and talked about obstructive sleep apnea. Thank you. OSA. They always use initials, you know, in medical.
Yes.
And so obstructive sleep apnea. Basically looking at the process that we are utilizing for patients who have obstructive sleep apnea. They're looking at identification. So in EPIC, we can have what we call a best practice. It's a way of firing something to remind the medical staff. So if a patient screens out, has triggers for potential for sleep apnea, then this will pop up for the medical staff, and then they will see that and then say, oh, okay, then they can talk to their patient, like, hey, would you like some testing? Would you like to go further with this? So that was kind of the first part of the process. Looking at treatment, you know, obviously we do sleep studies here at Myrtue Medical Center, and there are also some home studies that are out there that are not as in-depth as like a sleep study, but different, you know, different steps that they can take looking at sleep apnea. Currently we're doing about 150 a year, and they'd like to see that kind of increase if we do more screening and finding more patients. Then the tracking of once the patient does have CPAP or goes on to some sort of treatment measure of how to track that. And then obviously what we want is the improvement of patient health outcomes to improve. So talked about that, a little bit of a new protocol, making it a little easier for the medical staff, and the medical staff did approve that protocol this morning. Let's see, Kim talked a little bit about the weekend coverage. So starting on January 20th, we will have Monday through Thursday, the clinic will be taking appointments from 7 a.m. to 8 p.m., Fridays 7 a.m. to 6 p.m., and then Saturdays 8 a.m. to 4 p.m., and Sundays 11 to 3. So expanding those hours starting on the 20th of January.
How will you market that?
I'm sorry?
How are you going to market that?
The weekend hours in particular?
Yeah.
So we'll have a advertising campaign that includes multimedia,
Okay.
social media, print.
Because that's a big deal for our town.
Oh, yeah.
I mean, I think that really needs to have a lot of spread put on into it.
Yep.
Yeah. Great.
Yep. We've already done some photography with some professional photography with our providers, and just getting that all in alignment for timing.
Good.
What was the date again, Karen?
It's January 20th. Excited about that.
Sorry to interrupt you.
No, you're good. I just get on a roll sometimes. Kim also talked about we're going to have a new interpretive service. So basically, if a patient comes and speaks a different language, it's a new way of doing that. It's an iPad now, and there was pages of language that are actually face-to-face. So the patient comes in, they get the iPad, they can just find their language. It's written in both English and their language. They click it dials up an interpreter, and then they just take that iPad with them everywhere they go throughout their appointment and everything, and that interpreter will help them with their whole visit. So pretty exciting new technology that we have.
Currently we use interpretive services, but they're all audio. We do have the option for video, whereas we're transitioning and making this all completely video and then only audio if we run into difficulties. So it'll be good.
Very nice.
And that will be everywhere, so everywhere from ER to clinics, wherever, even just for lab, if you're just getting your lab drawn, so wherever they need it. And then last, Carrie Sonderman from Diagnostic Imaging and Mary Peterson presented another project. This is low-dose CT scanning. It's basically for lung cancer. So patients come in, what we're looking to do is diagnose this sooner. So if you do have potential for lung cancer, we're diagnosing it sooner. Patients have better outcomes. So basically when patients come in, there are a lot of screening questions we ask about tobacco use, if you smoked, how many packs per day, lots of different screening questions. If they screen out or they qualify for the low-dose CT scan, then the process, we discuss the process with the medical staff. There's a new dashboard in Epic so that once a patient has been identified, then Carrie in Diagnostic Imaging, she could follow that patient. So if they've been identified and there's some question on there, then she has they can follow up in 3 months, 6 months, a year, etc. Very similar to mammography and how we do that, only this is for low dose lung scanning. And it is a CT scan, but again, it's very low dose and it only takes about 5 minutes. So it's pretty quick. So I'm hoping to, again, catch some more patients, catch them early and get them through the process a lot faster.
Is that an annual test or depends on what they find?
It just depends on the screening. So again, you have to be between 50 and 77 years, how many packs per year that you've smoked, and then you have to have quit within the last 15 years or be a current smoker. And those are the criteria if insurance will pay for it. Now, anybody could have it. Say you're worried and you want to have it, you can come in, but the problem is that your insurance might not pay for it, so we would have that discussion with you. So anybody can have it, but that's what insurance pays for. And that's all we had, unless anybody has any other questions for me.
Questions for Karen? Okay, Laura, quality improvement report.
Okay, our last system-wide quality improvement meeting was November 15th. We had 10 departments that reported at that meeting. Diagnostic imaging monitored imaging rescan rates, which we want to be under 6% for patients being called back in for that, which it was 4.3%, as well as breast cancer screening recall rates. We want that to be under 9.4% for the national average, and we are at 9.1%. Dietary monitored the accuracy and temperatures of 3 different diets. They changed their monitors a little bit, so they looked at a full diet, clear liquid diet, no added salt, as well as decrease in diabetics hemoglobin A1C levels after that dietary education, and that was they saw an overall decrease of 1.6% in the patient levels. Emergency department reported they had 67 transfers that all met the transfer communication guideline. The average provider to patient evaluation time was 20 minutes was the average. And then stroke patients, we want that CT scan interpreted within 48 or 45 minutes, which was reported that it was 38 minutes. Environmental services evaluated appropriate disposal of sharps containers and compliance with soil, linen, bag fill capacity. Marketing evaluated the accuracy of 58 publishing documents that were released, and all of them were at 100% accuracy. Maintenance monitored compliance with facility-wide inspections, and all measures were met there. Pharmacy reported no adverse drug reactions, and then we still have that continued focus on opioid prescriptions for patients that we really don't want to have them on tube, if at all possible. So we're monitoring that closely on a weekly basis. Rehab services, they do a lot with fall risk screening, and they're kind of turning their focus that for patients that test positively for that they develop that plan of care afterwards. So they're kind of shifting their focus a little bit that way. Kim reviewed all of the ACO measures and where we were at on that. That was also presented to the medical staff this morning, and they look really good for the measures that are aligned with the ACO. And Senior Life Solutions focused on kind of that communication at discharge, which they're communicating with patients at 30 days, 3 months, 6 months afterwards, and sometimes even beyond, to make sure that they don't have any needs. Some new measures coming up for the new calendar year of 2024. A focus for CMS is social determinants of health. So starting in January, any inpatient admitted to the hospital, so OB or on med-surg, will go through a thorough screening of social issues, food insecurity, transportation risks, housing, and utilities. So that's a new focus for 2024. And that's all I have.
Karen, we're back to you for the approval of the joint conference committee revisions.
I will pass around, here's the book with all of the policies and procedures in them, but I'll go over them kind of in a brief here. So we went through the full policy and procedure manuals for credentialing, discharge planning, education, fiscal services, infection prevention, marketing, OB, pharmacy, purchasing, quality improvement, rural health clinics, and the safety manual. So those we would have gone over in previous meetings. So new quarterly policy and procedures for July through September of this year. Home health had some changes to both their, like some backups and some backup names and times. So minor changes to that, and then they added the Medicare HMO to their policies. Human resources had quite a few. Retired and senior volunteer program, the RSVP program, where we have volunteers who will assist patients in getting rides to appointments, etc. So that was a new program and a new policy that was formulated. And then the retiree wellness, Peterson Family Wellness Center membership discount. So any employees can receive a 20% membership discount if they retire at 55 or older and have been here for at least 10 years. So those were two new policies. Revisions were to the influenza immunization program going into flu season. Took out some references to COVID-19 vaccine. No longer making the influenza vaccine mandatory, but it's very strongly encouraged. So that was changed. The absence and tardiness policy, we used to have a point system, and now it's just gone to kind of a rolling calendar, and instead of points, just how many absences within that time frame and what we would do for employees who are having a few too many. And then for benefits, we did have a diaper discount through our vendors, but the vendors no longer provide that, so that was removed. And then workplace violence and terrorist threat, that was a policy that's actually in the safety committee policy, so we just left it in the safety committee and took it out of the human resources policy book, so just a small change there. Nursing administration, we have Tiger Connect communication platform, and we have formulated a policy for that. And then our nursing staffing and scheduling, we eliminated mandatory on-calls. We have requested on-calls, but no longer have mandatory on-calls for staff. And I think that was it. So unless there's any questions, I do need approval for the policy and procedure revisions.
If I could get a motion for the information that Karen's provided.
I move approval of the policy and procedure revisions.
Thank you, Kate. Second, please.
I'll second.
I have a motion and a second. All in favor, please say aye.
Aye.
Same sign. Jim, we don't seem to have any information for Personnel Committee.
Personnel Committee met at 10:30 today. There were no initial appointments, no reappointments, and no voluntary withdrawals. So that's all I got.
All right. We also received resignation of Tom Cannon, one of our Board of Trustee members. I think just recently was,
Yeah, just in the last couple months, so.
Right.
yeah.
Right. I mean, we knew it was coming, but he's moved out of the area, so. Okay, and with that, then I would like to have a motion on James Beaker to take his place. The information on James was in your packet. If I could get a motion on that, please.
So moved.
Thank you, Jim.
I'll second.
So he'll be building out Tom's term, which will go through the end of '24.
Okay. All right. We have a motion and a second. All in favor, please say aye.
Aye.
Opposed, same sign.
Will he get sworn in next month then?
And I didn't know if he'd be here today or not. I guess we have to appoint first. All right, Barry, CEO report.
I don't have a lot today, but did want to let you know that we are going through our insurance renewal process for 2024. We had them out, the broker out last week. We're going to get some more information that we're going to take through the finance committee. And I don't know if we have that meeting set up yet. I think here in the next couple of weeks we'll have that meeting and go through a lot of detail. We are going to see an increase in our property coverage again. And then also malpractice is going to go up this year. And we'll go into a lot more detail at that finance committee meeting. And then probably more of a summarized version will come back to the board, the full board in January for kind of final approval of those, of that insurance coverage for 24.
Does that take effect July 1 of 24?
January 1 this year, yeah. So we'll have the finance committee approve it and then kind of have the board ratify that. So that's one item. Master facility planning. We've had several meetings with the stakeholders, medical staff, department managers, several other staff have been involved in that. Our next step is to have a visit to a couple of facilities. We're going to do that next week. That will include 5 of the providers, Jeff and Drew, myself, Kim, Christy, Jill. We'll have several people involved on those visits. So we'll be looking at a clinic in CHI clinic in Omaha, and also be looking at a clinic, actually the hospital in Beatrice, Nebraska just recently did an addition for their physicians clinic. So they have different models, different type of model than what we have here currently, on stage, off stage, in a hybrid model. And that's really what we want to take a look at and see how, mainly it's for the providers to get a feeling for how the workflow would work under a different model like that. So I think the next step then will be to regroup with the full medical staff in January. We will still have several other meetings with med-surg director, rural health clinic manager, and then specialty clinic as well. So there's still probably 2 or 3 meetings left before we will have a kind of an end product for the board to look at for the master facility plan. So I'm thinking that's going to be February, maybe get moved into March for master facility plan. Any questions about any of those items? That's really all that I have today. And maybe I just have Jill. Do you want to talk about our visit on Thursday briefly?
Sure. So this Thursday, we are hosting a physician resident who's interested in Myrtue. So this individual, he is a second-year resident, so would be available in 2025. He's currently in a residency program in Michigan and has some family ties in Des Moines, so definitely wants to get to this area. Also has a strong interest in OB, so is in the OB track, and considering fellowship, but really interested in our opportunity to proctor once on site. So he's going to visit with our medical staff this Thursday, and we'll show him around the community and give him an experience. Him and his wife and daughter are also going to be joining him, giving them an experience here at Myrtue.
That's all that I have.
Okay. Any questions for Barry? All right, Jeff, it looks like we have the fire detection system is next.
Yes. Don't know, everybody knows Drew Becker. He's our Director of Facilities. I'm going to have him give a little bit of a history so far on our fire panel.
All right, so with some new state reporting and regulations come up, led us to look at changing vendors on who did our inspections on our fire system. After those inspections were done, we changed vendors, we got the inspections. We did end up finding some deficiencies. So our current system now is kind of a proprietary system. not what I would call in the top 3 of serviceability. So the company that installed it is basically the company that can service it. So we ran into a lot of hurdles trying to look at those deficiencies to get them fixed. It is zone-based, so when it does go off, it gives us, it'll say clinic first floor, and then we got to check 40 different heads to see which one actually went off. Not real efficient in emergency times. It is aged about, I'd say 15 years, or saying 15, 20 years on lifetime of a panel. Ours is pushing about 12 years right now. We do have issues with certain areas. The detectors and the horns and strobes are not working in key areas. We did do a lot of troubleshooting with our new company. Like I said, not much of a fix besides rewiring, going in depth. A lot of expense to not a lot of benefit, I guess. And we're at capacity. It's really not expandable. So looking forward, it's something that we would have to look at in the long run to, change before we did any more expansions. And just overall safety concerns of our patients, our visitors, our staff, of not being able to be notified, or if something were to happen, just the system not going off.
So one other note to that, we migrated to the one vendor. They replaced 4. We had a vendor that managed our FM200, which is the fire suppression system in the data center, one that managed all of the sprinkler systems, one that managed the actual panel and the smoke heads and
Fire extinguishers,
and hoods and everything. So this new vendor was able to replace all of those 4 and at a better price. So we were able to save money there. But as through their investigation, and this happened not quite a year ago, but through their investigation, as Drew mentioned, we found a lot of deficiencies and such. So the upgrade we've gone through, we actually have it in place. When we upgraded the elevators, we needed to expand the existing fire system, which we couldn't. So we ended up getting a new, what's called a head end, or the control of a fire suppression system. So we were able to put the elevators on that, both elevators. The ED is planned to go on that system, and it is addressable. So when one of those alarms go off, we know exactly which head and what the issues are, because we have heads above ceiling, below ceiling, and in ducts. So you can imagine it's a challenge when you say go to the first floor and that's where our fire or smoke detection is. So with the new system throughout the entire hospital would be new wiring, new smoke heads. It's expandable and also meets all the current life safety code. Our current system has been grandfathered, as for example, our horns and strobes are too far apart. They would correct that deficiency, and so we would have a better notification system. So we investigated a number of companies. They go basically by square footage throughout an entire hospital or facility. Associated Fire came in at about $2.40 a foot. Lincoln Company, $2.80, and we could buy directly from Siemens if we need be, but they're over $3. So they prefer not to do the installs. They would rather have a sub take care of it. So the total cost of the most cost economical solution is with Associated Fire. Total cost $287,000. It comes in as about a 6-month project, so we would be transitioning certain areas at a time instead of just all at once. So at this time we would request approval to move forward with the fire detection system with Associated Fire for a cost of $287,050. And we would love to answer any questions you have.
My only question is it in our budget to be able to do that? You're talking about the next 6 months?
Right, we did request it in our budget as part of last year's planning.
Okay.
And it's just taken this long to get responses from vendors and understanding, because they wanted to come in, look at what we have, what the layout is, and try, kind of formulate what is the equipment and the manpower that's going to be needed.
Could we spread it over 2 years because it's got that 6-month window, or?
The issue might be is we have a number of horns and strobes that don't sound, so if we were to have a fire alarm, we could go through and try and prioritize.
I mean, as you're doing it in
Sure.
sections, I mean, wouldn't that
And pay for
part
what
of it
was
this
been
year and
done.
part next year?
It's definitely a question we can ask.
It'd probably cost us more to do it that way.
Okay.
Yeah, when we budget though, I mean, like if we start a project, like this would be approved now, and it comes out of this year's budget, even though some of it's spent maybe next year, like the final couple rounds of invoices wouldn't be paid until next year, it'd be
It's
out
still
of
all
this
this
year's
year's.
budget.
So will this system grow with us?
It is expandable, so, you know, through the master facility planning, any changes that may be required, or that we do as part of that, and may require different fire requirements, this can accommodate anything and everything that we have potentially planned for now.
So the cost, the person that's going to provide it, it won't be the end servicer, though. Siemens will be the end servicer?
No.
Associated would install, they do all of our inspections and stuff.
Okay, so that I'm confused, though, you're having Siemens do the elevators and the...
No,
No,
that's
it's-
the name of the
It's a
product.
Siemens brand panel
Yeah.
Okay,
product.
okay. I was just
So-
curious, because
Yeah.
I saw those names and okay.
Yeah, Siemens is probably the industry standard throughout. So if we do need service, we don't like Associated Fire for whatever reason, there are numerous around the 100 miles that we can go to get service for it.
Yeah, when I first started looking at this, I approached Chris and he gave us a list of, I'd say, the top 3 brands out there to pursue that would be able to be picked up by other vendors, so we wouldn't be in the same predicament we are now.
Any other questions? Oh, sorry.
I'll move to approve the purchase or installation of the fire suppression system or detection system as presented.
Thank you, Terry. Second, please.
I do have one more question. Can I ask it? This is outside of what's already going to cost us to do the ER, right? This is just additional for the hospital?
Yeah.
Second that motion.
Thank you, Kate. A motion and a second. Any other questions? All in favor, please say aye.
Aye.
Opposed, same sign. Motion carries.
Thank you very much.
Thank you.
Oh, Jeff, the water softener system.
Yes, I have with us Chris Burnham. He is with SES. They are the lead engineer for our Central Utility Plant project. Thought we would be done with it, but we still have a couple things to talk about. But I'm going to have Chris maybe start off as to, we have a system called Easy Water, and what it is, why it was selected possibly, and we'll go from there.
Yeah, to walk you through it, I mean, as you know, we've undertaken over the last 3 years a pretty substantial upgrade to the central plant. Back then it was, the hospital had gotten their money's worth definitely out of the equipment in the plant, so it was a pretty comprehensive solution to go in and keep it in its existing location was another challenge through a relatively complex phase replacement to upgrade all the systems, chilled water, heating and all of that. One of them was the water service to the hospital, so we have a new water service from the utility that goes into the central plant. Part of that is a solution related to treatment of the water before it gets utilized throughout the facility. Originally, the hospital did have a softener system. So with the design of the plant, not unlike any other systems in the plant, we worked with the vendor to identify a good long-term solution for the facility for water treatment as it comes into the building. And
Prior, we only had hot water that was softened.
Oh, true.
So we did not have the cold water softened, it was only the hot.
So with that, worked with the vendor to a water filtration vendor to identify the best solution for the facility, and they brought forward a 3-part solution for that. Ultimately consists of 3 different elements. One is sediment filtration, so it's essentially a sand filter that filters out any sediment that you would get from the city water system. And I'll jump out of order here, but the second one was UV light system that would, any of the water coming into the facility that would provide bacteria disinfection related to the water supply. And then no salt conditioner was really an element to essentially replace the need for a softener by one, helping to descale the existing piping. So I think Drew's probably got some examples that we can show that we definitely walked through here a few years ago when we talked about the plant upgrade and the scaling that you've seen on existing water pipe in the facility. But then also, as it indicates, no salt would, minimize your maintenance need as it relates to treating the water and not having to have salt related to that. But as we've learned, that's created some challenges with the facility that we'll walk through here.
So the challenge is when they talk about, it's a conditioning, not a softening system. And what it does is it changes the molecular structure of all of the minerals that go through the water, preventing them from accumulating. So in cases, we'll actually reverse some of the scaling in the pipes. So it sounded like that would be a great solution for the hospital. It was going to be real great. We have been running those solutions for over a year. However, the filtering, we haven't because of the backflow issues and a number of things. And it does not remove the minerals, it just changes them. So the water hardness entering the system is the same as when it exits the system. So, but again, it changes that structure so nothing accumulates together. The problem we were running into is in our humidifiers and sterilizers. It heats, boils the water. Well, those minerals are still in the water, and once that kind of concentrates, those minerals then start attaching themselves onto the heating elements and creating a lot of scale, therefore causing problems. The sterilizers are for our equipment to sterilize the operation tools. The humidifiers go to all of our air handling units to provide the humidity that's we need in the wintertime and such. So the problem we had is we are on a monthly basis going to descale either a humidifier or a sterilizer, a number of them. We actually have one or two humidifiers that we have not even turned on from the cut project to try and prevent them from having the issues the others are. So going with a water softening system will not eliminate it, but definitely minimize any of the scaling that may be occurring. So we have had two bids. Manili Mechanical is the entity that did all of the cup work. They bid, their solution is to take the existing equipment, and there's two, some of you saw two big green tanks. They're about, 8 foot tall, about 4 feet around, and they're full of that medium that filters. Their solution is to remove all the medium that's out of there and replace some of the hardware and turn those into a water softening system. Also leaving that molecular changing of the water and the UV lights. Comes in, $121,000 for all of that. The second, Proctor Mechanical, who is currently working in the ED for all of the work there, provided a bid, basically remove those two tanks, replace that with a Culligan water softening system, and again, retaining the no salt conditioner and the UV system. So trying to retain as much as we can in the most processes. So and with that, we are requesting to save a lot of our equipment and future expenses that we requesting approval for the Proctor Mechanical water softening system for $105,419. And please ask questions.
I got one.
Sure.
What is the difference between the monthly costs of these different systems compared to what we're paying now? I mean, you always have, a Culligan system I know you pay monthly for.
Yeah, I mean, we'll have a salt expense that we will have to accommodate, and that's probably going to be about it.
Yeah, there maybe on both systems you'd probably have either a quarterly or semi-annual, annual check of the system where a representative comes out, but we already have, I call him our chemical guy, but we have a company that's already contracted with, that comes and checks all of our loops and everything, and he does a water hardness check. So when he comes out every 2 months, he will do a water hardness check to make sure that softening system is running the way it's supposed to be.
That's not really what I meant. What I meant was the kind of materials that you're going to need to buy monthly
Yeah.
just to keep the system running.
Yeah, right now it would be just the addition to the salt, which we were able to get rid of salt for a short while. It's a very similar system to what we had before with just the hot water, but we'll have it on both hot and cold now. So as to how much salt, I couldn't tell you right now.
Yeah.
Because there's not much difference in the bids, but the first one doesn't use salt, is that correct?
There would be a salt solution.
Both of them, okay.
Yeah,
They're
yeah.
both salt solutions.
Yeah.
I was misunderstanding that. I was
Yeah,
thinking
no,
one was salt, one wasn't.
The original current system is a no salt solution, no salt conditioning system. That's the part that changes the molecular structure of all of the minerals in the water. That will remain. That portion will remain. And so we'll change that molecular structure. So if any minerals do get through the softening system, they will be changed in such a way they won't accumulate within the pipes. And we'll still get some of that benefit that a lot of the scaling that's in the pipes already could start to be reversed a little bit. But it aids with the softening system to make it even more efficient.
What's the estimated life of a system like this, and what's going to need to be maintained or repaired soonest?
Yeah, I believe it's roughly 15 years also. And the maintenance would all depend, I mean, there's a head that's going to monitor the throughput of water and pump and monitor the condition of the water. I'm not sure what other maintenance there would be, but the materials inside, the salt, just kind of think of our home ones, but on a really grand scale.
Okay.
Yeah.
That's very, very similar. You do have the valve, that's one of the lifetime concerns, and then the resin that's in the tank itself needs to be replaced eventually, but it's on that 15-year timeline.
Yeah, and it is redundant. So that's the 2 tanks, one runs at a time, and when it's time for that one to backwash, the other one will kick in and run. So it is a redundant system as well.
Are there any other questions?
Jim's got a smile.
I guess, how did we miss this piece on the first part of it when we put it in?
Yeah, so essentially, like we mentioned before, they came forward with a 3-part solution, and their suggestion is that they didn't realize that we had this need, that we were in a scenario where we're boiling off water. Ultimately, didn't necessarily have this scenario with the original boiler system. I mean, the plant upgrade improved a lot of water saving and energy saving, and getting rid of the steam boilers was an element of that. But what we had to come back with, which you would with any upgrade of this nature, was targeted steam generation for the sterilizers and then the humidifiers as well. Those were generally coming off the central boilers. So the vendor didn't recognize that there was that additional need, that we were boiling water off. So their no salt system sounds great. No salt, anybody would love to have a softener that doesn't require you to manage salt, but it doesn't wash the minerals down the drain like a softener would. So there just wasn't a recognition that their system didn't provide that capability. So in retrospect, they're saying we really should have sold you a 4-part system that also had the softener. So it was an additional piece that
So we can't
really needed.
So that original bid, that additional piece, is that what they were going to put onto this thing then?
That's what we would add. This is the 4th component that we would add that addresses these.
But we're not going to.
And due to space constraints, we can't. We don't have the space to keep the existing and add a water softener, probably without, we're going to have to add an addition onto that utility plant in order to accommodate it, and that's not feasible. This is actually pulled from their web advertising, that it does remove 99% of sediment, which that sounds like you're going to have pretty good water coming out of the system. But it doesn't say that the hardness remains in the front and the back, it just changes that. So you're led to believe that it is softening all the water. Prevents and adds, removes the scale buildup. Understand what that is now, and obviously UV is self-explanatory almost. But it's, when it says removes 99% of the sediment, that means, to me anyway, that it is clean water coming back out.
And what's the response when you say that to them?
Exactly kind of what Chris said. We did have a meeting with the vendor, the contractors, SES, us, a number of people, and they said, well, because we are boiling the water, that is where the issue comes in. He also said that, admitted at that point that it does not remove all of the minerals. And we did point out that your advertising then is not correct.
I mean, that's normal to boil water.
Yeah. For humidifiers and such. Yep. But, yeah, I mean, it's all the heating and all that.
So I would move the approval of the Proctor water system at the $105,000.
Oops, sorry, going the wrong way.
Quote amount. We'll just put it in there. 105,419, yeah.
Okay, Terry's made a motion on the water softener system. Purchase of. Have a second, please.
I'll second.
Second. All in favor, please say aye.
Aye.
Opposed, same sign. Motion carries.
Thank you very much.
Jenny?
Hopefully mine's a little more fun than salt and.
We're here today to talk about our new monitors for the new edition for the emergency room. This is the team that's been working. We meet weekly to discuss planning and purchasing and of the project. So we're proposing that we buy 9 patient care monitors for our 9 new rooms, 8 patient care rooms and 1 triage room for the new emergency department area. We need to upgrade the network infrastructure facility-wide to accommodate those new machines. They have new software, so they can't go on our current system. So we need a bit of an upgrade facility-wide to accommodate those. And I don't know if Jeff has anything he wants to add related to that. No. And then the biggest reason we're coming to you now to buy them now as opposed to maybe July 1 is because we have to get on their education schedule. We can't roll out any new machines until we are educated on the new machines, and that schedule for them is about 9 months out from now. So we really need to go this month to get purchased on their education schedule to have those clinical RNs come educate us on the new features of the machines. And then, so also payment we have to pay to have them come install them into our new emergency department. And then we're adding in a replacement of the endoscopy monitoring equipment for the surgery area. And Karen can speak a little bit to that.
So we have we need more features, I guess is what I'm trying to say. So right now they have a monitor, but they have a separate feature for this, and this just brings it all into one monitor. So since we are doing the full facility upgrade, this is something they were going to need anyway, so we went ahead and added that on.
Advanced gas monitoring is what they're going to be adding for that.
And one other comment on that is the reason we're coming to you today versus having it as part of the rolled up into the emergency department upgrade is because this affects the entire hospital. We had to upgrade the entire system in order to accommodate just the new addition of equipment for the ED. So that's why it's kind of separate from the ED but tied to it also.
We pulled it out of the project, but it's still budgeted.
Okay.
Yeah.
Did the old monitors work on this infrastructure too? The monitors that are...
Everybody else's monitors, yes. Yep. So the new monitors are Mindray N12s and 15s. The 15 and the 12 and 15 just mean the size of the screen. ERs will get the 12s. I believe endoscopy is going to get a 15-inch. But of course, have heart rate monitoring, blood pressure, oximetry, which is your oxygen level, EKG monitoring in any room. We can do an EKG without having to go find the machine. Any room, you can just do an EKG right away. Prints off at the central station. We have that in 3 of our rooms right now, and it's really nice. We really like it a lot. CO2 monitoring, we use that a lot on intubated patients getting narcotics, and then that specialized airway gas monitoring for the CRNAs in surgery. Benefits, we'd have improved patient outcomes. Like I said, we can do EKG instantly at the bedside instead of going to get the machine. CO2 monitoring in every room. Even if they're just here for a leg fracture, you give them a little morphine, it's good to monitor their carbon dioxide and make sure they're not too sedated, and that's important. Standardized machines in every room. Right now we have a couple different machines at different ages. This will make every machine about the same age and used the same. Improved central station, I'm kind of excited about this. We'll have a central station. What that means is you can see what's going on in the room at the desk. And then what we're also going to do is put bigger screens up on the walls outside of the nurse's station so you can just see at a glance what's going on with that patient, even if you're busy in the halls. And then also the physician in their dictation room will have a screen so they can see what's going on too. So you have lots of eyes on those monitors. And then increase patient safety in that endoscopy room with that advanced monitoring. And then staff will be happy to have up-to-date monitors. Growth currently, well, as you know, we're going to go from 5 to 8 rooms in a triage room. So that's our growth. And current, the ER has the oldest machines in the building. Right now they're about 10 to 12 years old. They're just workhorses. They work 24/7. I really don't have any problems with them breaking down. They last a long time. We just need new ones to be able to be standardized, and once we update, we can't buy any new old stuff, so we can't buy any new DPM6s. We have to buy those N12s or N15s to go to the new central station. And we do anticipate being busier with our new ER. If you build it, they will come, hopefully. And then 3 of our 5 machines are at end of life. Those are the 10 to 12-year-old ones. All of the 9 monitors were included in our construction budget, I guess, in the capital budget. We had $175,000 in there. Anesthesia had $13,000 budgeted for their new machine, and our current quote is $174,000 for $63.80. That's just a picture of our new area. Any questions?
I'll make a motion to approve those purchases.
I'll second it. A motion and a second, all in favor, please say aye.
Aye.
Thank you. Opposed, same sign. Motion carries. Christie?
Just to go through our October financial, November, it usually takes us more than 10 to 15 days to get financials done. So we're still doing October. Our outpatient visits in October of 23 were quite a bit higher than what they were in October of 22. So we had 5,300 outpatient visits compared to 4,873 last year for the same month. Year to date, which is 4 months into this fiscal year, we had 19,767 compared to 19,018 for last fiscal year. It's a 3.9% increase. ER visits, pretty similar this year in October to last year in October. Year to date, we are down approximately 80 visits there. And so it's about a 4%. Smaller numbers, you have bigger percentage changes. So surgical procedures were, again, consistent this year with 124 compared to 125 in the month of October. 468 this year compared to 436 last year, so we're at a 7% increase. Nice to see that rebounding quite a bit. So physician clinic visits, this October was a little bit busier than last October at 3,682 visits. That includes whether a patient's coming in to see a nurse to get a coag taken, or a nurse in immunization, or a physician. Includes both those services. Year to date, we're at 14,134. Last year, we're at 14,317, which is a 1.3% decline in those. Behavioral health visits, we were at 1,269 compared to 1,556. Last year in October, a lot of staff replacement this summer, a lot of staff turnover. So year to date, we were at 4543 compared to 5436 last year.
Does the school play into any of that piece of not being
Some of it.
anymore?
Because some of those patients could not transition to our facility because of transportation needs.
Sure.
Or the availability of parents to bring them, so that does take into consideration there. Average daily census is a combination of our acute OB patients, swing bed, and observation. So we're at 6.22 patients per day in October of this year. Last year we were at 8.11. Year-to-date, we're at 7.09 patients per day, and last year for the first 4 months, we were at 8.88. So have seen a 20% decline in our inpatients. Most of that comes from our swing bed. Insurance companies want patients to go to nursing homes rather than staying in the hospital. Births, we had 8 in October of this year, 10 last year. Year-to-date, we're at 25 compared to 37 last year, which is a 32% decline. We had a 3.6% increase in our operating revenue from last year to this year, year-to-date, and a 4.5% increase in expenses. So there is a little bit of a gap there, so we are seeing an operating loss this year, year-to-date, for $82,000 compared to $70,000 profit last year. We are seeing better returns on our investments at this point, so our non-operating has increased 59%. So year-to-date, we're at $387,000 in net from all sources compared to $365,000 last year. So staying pretty consistent with what we had last year. Go to the next screen. Jeff. So I still comparing these, kind of during the pandemic now to where we are. So go through the same process with outpatient visits. You can see they just continue to increase, which is the trend. ER visits, we saw an increase there a little bit in 2021. Has come back down slightly since then. Surgical procedures, we rebounded with, first we're seeing that we completely rebounded to pre-pandemic number of surgeries. In the first 4 months of 2020, we saw 468, and that's exactly where we are now too for this first 4 months. Behavioral health visits, we saw an increase there in 2022. We're kind of back to where we were in 2021, but we're anticipating that will grow here now that we've got staff in place and they're building those clientele. So again, average daily census has been at 8.14, 9.84, 8.88, and now we're at 7.09. In births, the last 4 years, we were at 16, 28, 37, and 25. And you can see there our net income has kind of peaked there a little bit in 20 and 21, and 22 and 23 are pretty consistent with each other. We are seeing an increase in our accounts receivable a little bit in the area of patient responsibility. Really the pandemic, when people weren't going and doing anything, they were paying off their medical bills. Now with groceries and everything costing more, we're seeing that turnaround again. So we'll continue to monitor that. Any questions on the financial reports?
Any questions for Christy?
What would that number run? Like, is there a percentage of it?
We were trying to we've been down around 51 days. You mean the percentage of
Bad debt, like people
bad
that are.
debt? We really tried to work with patients before we turned it over to bad debt. Let me just see here where we're at. This year, year-to-date, we're at $240,000 in bad debt, and last year we were at $142,000. We have taken another step where once we get a recommendation from our early out company to send them to bad debt, we do make one more personal outreach from the hospital to the patient, letting them know their options and what their payment plan should be based on our policies. Just again to try and get them to be able possibly look for another option to pay their bill rather than letting it go to bad debt, because we would much rather not send people to bad debt.
Are we doing small claims still then with them?
Yep.
Okay.
Any other questions for Christie? We get a motion on the approval of the financial report for October 31st.
I approve.
Thank you.
Motion.
Second, please.
Second.
We have a motion and a second. All in favor, please say aye.
Aye.
Opposed, same sign. Motion carried. The payroll and claims for November of 2023 are in your packet. At this point, we need an approval of those as well.
I'll move the approval of the November payroll claims.
Thank you, Terry. I have a motion, second, please.
I'll second.
Second from Mike. Motion and second. All in favor, please say aye.
Aye.
Opposed, same sign. Motion carries. We are at adjournment. Need a motion for that?
I'll make the motion.
Jim makes a motion for adjournment. Second, please.
I could second that.
Second. Thanks, Jan. Motion and second. All in favor?
Aye.
We are adjourned.